grasping how this condition is diagnosed and ultimately managed. So in this explainer, we're going to decode the structured complexity of heart failure classification together. We're breaking down the global diagnostic frameworks directly from the source material, and we're going to translate all that heavy clinical jargon into a clear, conceptual map that actually makes sense.
Now, to understand the rules of the game, you really have to know who writes them. We are looking at the absolute global gold standards in cardiology. We're talking about the ACC, the American College of Cardiology, the ESC, the European Society of Cardiology, NICE over in the UK, and the AHA, the American Heart Association. The classifications we're exploring today aren't just arbitrary groupings made up by a single hospital somewhere. No, they are the synthesized universal guidelines that literally dictate modern cardiovascular care worldwide. By demystifying the exact criteria these organizations use, we're looking directly at the architectural blueprint for how doctors everywhere evaluate and treat heart failure.
So, here is our roadmap for today. First, decoding heart failure guidelines. Second, left versus right heart failure. Third, the ejection fraction spectrum. And finally, pathology and diagnosis.
Let's jump into part 2, left versus right heart failure. We've got to think of the heart as a two-sided pump. Before we even touch those heavy acronyms, we have to understand this basic geographic split in the heart's functional failure. Left heart failure, or LHF, and right heart failure, or RHF, represent a macro-level division. They act differently, they present entirely differently in patients, and crucially, they're driven by very distinct root causes. Separating them conceptually right out of the gate prevents cognitive overload and really gives us the perfect starting blocks.
And here's where it gets really fascinating, because these two sides are intimately connected. In fact, the absolute most common cause of right heart failure is actually left heart failure. When the left side of the pump fails, it creates this massive internal traffic jam of pressure. That pressure backs up into the lungs and ultimately overworks and damages the right side of the heart. It's basically a catastrophic domino effect.
Let's actually contrast those root causes to really cement why this top-level separation is clinically critical. On the left side of the heart, the failure is typically caused by direct damage or extreme pressure on the left ventricle itself. So we're talking things like a myocardial infarction, meaning a heart attack, chronic hypertension, or cardiomyopathy, which is a disease of the heart muscle. But then, when we look at the right side, the causes are intensely tied to pulmonary issues. As we just learned, chronic left heart failure is a massive driver, but you also see things like pulmonary embolism and COPD. The right side is essentially forced to fail when it has to push blood against abnormally high resistance in the lungs.
Moving right along to Section 3, the ejection fraction spectrum. Now, to further divide up left heart failure, cardiologists use a very specific measuring stick, the left ventricular ejection fraction, or LVEF. Simply put, this is the percentage of blood leaving your heart each time it contracts. Think of it like this. If the left ventricle fills with 100 milliliters of blood and successfully pumps out 60 milliliters, your ejection fraction is 60%. And this percentage isn't just medical trivia. It is the critical threshold that dictates guideline-directed medical therapy, or GDMT, meaning this single number entirely changes the life-saving medications a doctor is going to prescribe.
This percentage creates a continuum of cardiac function. It's usually broken down into 3 distinct buckets. You have a red zone of reduced ejection fraction, a yellow middle ground of mildly reduced, and a green zone of preserved ejection fraction. It is technically a sliding scale, but for treatment purposes, the major guideline committees have drawn hard lines in the sand to separate these conditions.
Let's systematically walk through these thresholds, because global guidelines strictly organize a patient's entire treatment plan around these exact numbers. First up, we have HF-REF, heart failure with reduced ejection fraction. This is diagnosed when the LVEF drops to 40% or below. Next is HF-MRF, heart failure with mildly reduced EF, sitting in that really narrow 41 to 49% window. And finally, HFpF, heart failure with preserved ejection fraction, where the LVEF is 50% or higher. What's absolutely vital to grasp here is that in HFpF, the heart might actually be squeezing out a normal percentage of blood, but it's still failing because the heart muscle has become too stiff to fill properly in the first place. But remember, ejection fraction only tells us the type of failure. To fully classify a patient and unlock that optimal guideline-directed medical therapy, doctors also use the ACC-HHA stages of heart failure, ranging from stage A to D, to map the disease's structural progression over time. And on top of that, they use the NYHA functional classification, ranging from class I to 4, to formally score the severity of the patient's physical symptoms. All these systems work together.
So bringing it all together, this flowchart completely anchors everything we've just covered. The macro left heart failure classification funnels right down into the 3 micro LVF subclasses we just talked about: HF-REF, HF-MRF, and HFpF.
Meanwhile, right heart failure sits in its own category, fundamentally connected by that progression from left to right. This whole picture is essentially a clinician's mental map. When a patient walks in with symptoms, this is the exact rapid-fire pathway doctors navigate to categorize the disease and ultimately unlock the right treatments.
Which brings us to part 4, pathology and diagnosis.
There's a really fascinating rule of 3 that dictates both what is happening inside the failing heart and how doctors actually measure it from the outside. We have the shared pathology cycle, which is the internal mechanism of failure, and we have the universal diagnostic triad, which are the 3 external pillars required to officially make a diagnosis. Let's break each of these triads down.
Internally, heart failure is a continuous cyclical decline. It's a vicious two-way loop of structural and cellular degradation. First, ventricular remodeling warps the heart's shape over time. This is driven by cardiomyocyte changes. These are destructive alterations at the cellular level within the heart muscle itself. And those cellular changes? They lead to myocardial stiffness, which impairs the heart's ability to relax and fill, driving even further remodeling. And this relentless loop happens across the different subclasses of heart failure.
Now, to catch that cycle in action, doctors rely on the universal diagnostic triad. You need all 3 of these pieces to properly place a patient within our classification flowchart. Number 1, clinical assessment. This is where doctors check for physical symptoms like swelling or shortness of breath. And importantly, it's exactly where they assign that NYHA functional class we talked about to determine just how limited the patient's daily life has become. Number 2, echocardiography. That's the ultrasound imaging required to see the heart structure and calculate that all-important ejection fraction percentage. And number 3, biomarkers, specifically blood tests for NT-proBNP or BNP. These are proteins released when the heart muscle is stretched and distressed. It's only by combining the physical exam, the imaging, and the lab work that the clinical picture is actually complete.
We've seen how meticulously organizations like the ACC and ESC have constructed these categories based on distinct percentages and structural criteria. But it leaves us with a really exciting thought to ponder. As our diagnostic tools like molecular biomarkers and advanced imaging become exponentially more precise, how might these strict, hard-line guideline thresholds evolve? Will those 40% and 50% lines blur into highly personalized, AI-driven care models that treat the specific cellular changes rather than just the ejection fraction? It's a fascinating frontier in cardiology. Thank you so much for joining me for this explainer, and keep questioning the science behind the standards.